I do want to move on in the last few minutes we have to talk about some new drugs that are coming out. And let's start with selinexor, which has been approved by the FDA, and so it is available. And we have some updates recently on the Boston, I'm going to get the studies mixed up now, but the combination of selinexor with Velcade, and that is the Boston study. And anybody participate in that wants to comment on it?
Well, so the Boston study, we didn't participate, but the trial was presented at ASCO.
Despite the fact you're in Boston.
I know, but we didn't. So this was, you know, in response to the STORM data, which was what got selinexor approved. I think the nice thing about the Boston trial is they have used bortezomib on a weekly schedule. They have used it in a subcutaneous way. So it's more sort of real world way of using bortezomib. And the other thing they've done with the selinexor in this combination is they've used weekly dosing of selinexor, although at 100 milligrams. So that's something we can argue about. But having said all of this, you know, they did see a benefit in terms of a progression-free survival of about a little over 4 months. So I do think this is hopefully going to get the drug finally approved. As far as selinexor is concerned, I think most of us still worry about the toxicity associated with selinexor. And depending on what your partner drug is going to be, I think it's really important to dose modify selinexor so that it's well tolerated and patients can actually stay on medication.
So I just wanted, for our audience, I just want to step back a bit and just maybe describe selinexor a little bit for those of you who may not be familiar with it. It's an orally delivered agent. It has a novel target, which is exportin, a protein that shuttles, a protein that shuttles things from the nucleus into cytoplasm and back that can be blocked by this drug. So it's a completely novel mechanism of action. It is approved by the FDA now as a single agent in heavily pretreated patients. Refractory, they were called, five prior regimens with a response rate of about 26%, if I recall rightly. And this Boston trial that we've just described, I think we jumped right into it without explaining what it was a randomized phase 3 trial of bortezomib dexamethasone versus bortezomib dexamethasone and selinexor. It was mostly done in Europe because the control arm wasn't that attractive in the United States. But as Nupur just pointed out, about a 4-month progression-free survival advantage. Did I get that right? Kind of, sort of? If not, please correct me because I'll get in trouble afterwards. Anybody, Peter, do you want to comment on the trial and what you think about it?
Well, I think that this was a logical way for them to get regulatory approvals in earlier relapse. I think, given the fact that we have other proteasome inhibitor-based triplets that we've already talked about, daratumumab, carfilzomib dex, soon to be isatuximab, carfilzomib dex, pomalidomide, bortezomib dex, you know, in a similar patient population, just given the side effect profile that Nupur alluded to, I don't think we're going to be using this a lot in this particular clinical scenario.
Tom, what do you think? Are you going to be using it in late relapse?
So we've pretty much reserved the use at the current time in the really penta-refractory scenario where we don't have anything left. We don't have a clinical trial slot for a patient, and we don't have any other therapeutic options, and we've tried it. And it's a tough drug to give. There's no doubt about it. You have to be very diligent about checking their electrolytes, giving them fluids, giving them anti-nausea medicines, checking in with the patients. But that you do get some patients that you wouldn't believe that you get a response to. So I think it's reasonable to try in patients either in the combination of bortezomib, selinexor, dex, or just selinexor and dex. Give them a cycle, give them 4 weeks, make sure they get through it okay. And if they have a response, I think you can continue. But it is, in general, it requires a lot more work than all the other regimens.
Now, in fairness to the drug, when it was dropped to a weekly dosing that Nupur described in the Boston trial, apparently it looked like it was quite a bit better tolerated, right?
Yeah, we've been participating in what's called the STOMP trial, which is partnering selinexor with a lot of different agents. And we've been very impressed with 2 combinations in relapsed refractory patients, and that's carfilzomib with selinexor and dexamethasone. That has had a pretty good response rate, as well as daratumumab and selinexor. And I think like we learned with other oral drugs, to me, it seems like you actually get more drug in patients with lower doses. And we've been pretty aggressive at cutting the doses, and then patients really can stay on. And like Tom said, I think in some of these very refractory patients, there have been some dynamite responses. I think we just don't have a biomarker for it, to say who's going to be the person who responds, unfortunately. But there are some people that I've treated that have really benefited.
Yeah.
All right, I want to move. Thank you. I think that's a good summary of selinexor.